Welcome back, everyone. We continue our discussion on management of diabetes in pregnancy, a clinical update. Today's topic is the management of gestational diabetes mellitus. GDM is characterized by increased risk of macrosomia and birth complications and an increased risk of maternal type 2 diabetes after pregnancy. The association of macrosomia and birth complication with oral glucose tolerance test or OGTT results is continuous with no clear inflection point. In other words, risk increases with progressive hyperglycemia. Therefore, all women should be tested as outlined in the section on screening and diagnosis. Although there is some heterogeneity, many randomized controlled trials or RCTs suggest that the risk of GDM may be reduced by diet, exercise, and lifestyle counseling, particularly when interventions are started during the first or early in the second trimester of pregnancy. In the largest single trial of GDM treatment, investigators randomized 1,000 women with GDM to no treatment or to intervention with lifestyle modifications, blood glucose self-monitoring, and insulin therapy, if needed. Adverse perinatal outcomes defined as infant death, shoulder dystocia, bone fracture, and/or nerve palsy were 4% in the no treatment group compared with 1% in the intervention group. A more recent systematic review and meta-analysis that includes 5 randomized controlled trials and 6 cohort studies found that treating GDM results in statistically significant decrease in the incidence of preeclampsia, shoulder dystocia, and macrosomia. Let's discuss lifestyle management. After diagnosis, treatment starts with medical nutrition therapy, physical activity, and weight management, depending on pregestational weight as outlined in the section below on pre-existing type 2 diabetes and glucose monitoring, aiming for the targets recommended by the 5th International Workshop Conference on Gestational Diabetes mellitus, which is as follows. First, fasting of less than 95 milligrams per deciliter or 5.3 millimoles per liter, and either 1 hour postprandial of less than 140 milligrams per deciliter or 78 millimoles per liter, or a 2-hour postprandial of less than 120 milligrams per deciliter or 6.7 millimoles per liter. Depending on the population, studies suggest that 70 to 85% of women diagnosed with GDM under Carpenter-Costan or National Diabetes Data Group criteria can control GDM with lifestyle modifications alone. It is anticipated that the proportion will be even higher if the Lower International Association of Diabetes and Pregnancy Study Group IADPSG diagnostic thresholds are used. Initial treatment for GDM involves diet and activity modification. Women with GDM should receive individualized nutrition counseling from a registered dietitian, which commonly includes a recommendation to limit carbohydrate intake to 33% to 40% of calories. No high-quality data exists on the optimal diet for women with GDM. A Cochrane review of 9 small trials comparing different types of dietary advice did not demonstrate any significant differences in perinatal outcomes. Some but not all trials suggest that a low glycemic index diet may result in improved glycemic control. Medical nutrition therapy for GDM is an individualized nutrition plan developed between the woman and a registered dietitian familiar with the management of GDM. The food plan should provide adequate calorie intake to promote fetal or neonatal and maternal health, achieve glycemic goals, and promote appropriate gestational weight gain. There is no definitive research that identifies a specific optimal caloric intake for women with GDM or suggests that their calorie needs are different from those of pregnant women without GDM. The food plan should be based on nutrition assessment with guidance from the Dietary Reference Intake or DRI. The DRI for all pregnant women recommends a minimum of 175 grams of carbohydrate, a minimum of 71 grams of protein, and 28 grams of fiber. As is true for all nutrition therapy in patients with diabetes, the amount and type of carbohydrate will impact glucose levels, especially post-meal excursions. Although the few trials evaluating the effects of exercise on women with GDM have yielded inconsistent results, aerobic exercise and resistance training clearly improve glycemic control in patients with diabetes. Exercise for 30 minutes most days of the week is a reasonable goal for most patients with GDM. Attention to maternal weight gain is also important in minimizing the risk of fetal macrosomia. Maternal obesity, excess gestational weight gain, and GDM are independent and additive risk factors to macrosomia. For example, among women with obesity, GDM and gestational weight gain greater than 40 pounds, 18.1 kg, the risk of fetal macrosomia is nearly 40%. Although no specific intervention has been shown to prevent excess gestational weight gain, clinicians can counsel patients using the Institute of Medicine's 2009 recommendation on gestational weight gain, called Weight Gain During Pregnancy, re-examining the guidelines. Now let's discuss pharmacologic therapy. An elevated blood glucose level, despite lifestyle modification, is an indication for pharmacologic therapy. Although insulin has historically been the standard therapy for women with uncontrolled GDM, oral medications are now appropriate first-line therapies as well. Options for oral medications include metformin, also known as glucophage, and glyburide. Although neither glyburide nor metformin has been approved by the U.S. Food and Drug Administration for the treatment of GDM, both are pregnancy category B. Metformin and glyburide cross the placenta but have not been associated with birth defects or short-term adverse neonatal outcomes. However, data on long-term metabolic effects on children with in utero exposure are limited. Clinicians may consider counseling patients on the lack of long-term safety data for these medications. No consensus exists on the threshold values above which medication should be prescribed. Therefore, clinicians can consider gestational age, frequency and severity of blood glucose elevation, fetal growth, and patient preference. One approach is to begin pharmacologic therapy if more than two values at the same meal during a 2-week period are above target by more than 10 mg per dl or 0.6 millimoles per liter. Another approach is to initiate medications if 50% of the values in a given week are elevated. Treatment of GDM with lifestyle and insulin have been demonstrated to improve perinatal outcomes in 2 large randomized studies, as summarized in the U.S. Preventive Service Task Force review. Insulin is the first-line agent recommended for treatment of GDM in the U.S., while individual random controlled trials support limited efficacy of metformin and glyburide in reducing glucose levels for the treatment of GDM. These agents are not recommended as first-line treatment for GDM because they are known to cross the placenta and data on safety for the child is lacking. Furthermore, in 2 randomized clinical trials, glyburide and metformin failed to provide adequate glycemic control in 23% and 25 to 28% respectively of women with GDM. Sulfonylureas are known to cross the placenta and have been associated with increased neonatal hypoglycemia. Concentrations of glyburide in umbilical cord plasma are approximately 70% of maternal levels. Glyburide was associated with higher rate of neonatal hypoglycemia and macrosomia than insulin or metformin in a 2015 meta-analysis and systematic review. More recently, glyburide was found to be inferior to insulin based on composite hypoglycemia, macrosomia, and hyperbilirubinemia. Long-term safety data for the child is not available. Metformin was associated with a lower risk of neonatal hypoglycemia and less maternal weight gain than insulin in systematic reviews. However, metformin may slightly increase the risk of prematurity. Like glyburide, metformin crosses the placenta, and umbilical cord blood levels of metformin are higher than simultaneous maternal levels. In the metformin in gestational diabetes, the offspring follow-up studies analysis of 7 to 9-year-old children exposed to metformin for the treatment of GDM were larger based on a number of measurements than those exposed to insulin. In 2 randomized clinical trials of metformin use in pregnancy for polycystic ovary syndrome, follow-up of 4-year-old children demonstrate higher body mass index and increased obesity in the children exposed to metformin. Further study of long-term outcomes in a child is needed. Randomized double-blind controlled trials comparing metformin with other therapies for ovulation induction in women with polycystic ovary syndrome have no demonstrated benefits in preventing spontaneous abortion or gestational diabetes mellitus, and there is no evidence-based need to continue metformin in such patients once pregnancy has been confirmed. Glycemic control, maternal and neonatal outcomes, and adverse effects are similar among patients treated with oral hypoglycemic medications versus insulin, although glyburide may be associated with lower failure rate, in other words, need for insulin therapy, than metformin. Metformin is typically started at 500 mg once daily with food and titrated to a maximum dosage of 2,500 mg per day given in divided doses with meals. Glyburide is initiated at 2.5 mg once per day, 1 hour before eating, and increased to a maximum of 10 mg twice per day as needed. Between 15% and 40% of women initially prescribed oral medications for GDM ultimately require insulin. What about the use of insulin? Insulin use should follow the guidelines below. Both multiple daily insulin injection and continuous subcutaneous insulin infusion are reasonable delivery strategies, and neither has been shown to be superior during pregnancy. Insulin is required in women who have uncontrolled blood glucose levels despite lifestyle changes and use of oral medications, and in women who elect to avoid the trial of oral medications. Insulin does not cross the placenta. Rapid, intermediate, and long-acting insulin are considered safe for use in pregnancy. One approach to starting insulin therapy is to calculate the total daily dose of 0.7 to 1.0 units per kilogram. Half the total daily requirement is administered in a single dose of long-acting insulin, for example, Glargine or Ditamir, and the other half is administered in 3 divided doses at mealtime as rapid-acting insulin, for example, Lispro and Aspart. Insulin dosing should be individualized and adjusted as needed. Next is fetal assessment. There is no consensus on the optimal approach to fetal surveillance in pregnancies complicated by GDM. Antenatal testing in women who have GDM that is well controlled without medication is not beneficial because the risk of stillbirth is not increased in this population. Antenatal testing is commonly performed in women who require medication for GDM, although data supporting this practice are limited to older observational studies. The American College of Obstetric and Gynecology recommend that clinicians perform antenatal testing in accordance with local practice patterns. Such testing could include twice-weekly non-stress tests or weekly modified biophysical profiles beginning at 32 to 34 weeks of gestation. The role of ultrasonography in pregnancies complicated by GDM varies among clinicians and institutions. Some physicians obtain serial ultrasonography, separated by at least 4 weeks, to monitor fetal growth in patients with GDM. Several small trials have found that instituting tighter glycemic control for women with accelerated fetal growth may result in lower incidence of large for gestational age infants. However, larger studies are needed before routine use of ultrasonography to guide management of GDM can be recommended, especially because undergoing third trimester ultrasonography may be an independent risk factor for cesarean delivery. Other physicians perform ultrasonography near the end of pregnancy to assess the risk of fetal macrosomia. However, a sonographically estimated fetal weight of greater than 4,000 grams is only modestly predictive of an actual fetal weight greater than 4,000 grams, with a positive likelihood of 5.7 and a negative likelihood rate of 0.48. Among fetuses weighing more than 4,000 grams, clinical estimates using Leopold maneuvers and fundal height measurements are as predictive of macrosomia as ultrasonography and appear comparable to the estimates of Paris women of their baby size. The American College of Obstetric and Gynecology recommends that clinicians assess fetal growth in patients with GDM late in the third trimester, stating that ultrasonography or clinical examination is appropriate. Now, what about timing and route of delivery? The optimal timing of delivery in pregnancies complicated by GDM is unclear. Given the neonatal risks associated with early-term births, induction of labor before 39 weeks should occur only if glycemic control remains poor despite medication use, or if another indication for delivery is present. Limited evidence suggests the induction of women with GDM at 39 weeks compared with further expectant management is associated with a lower risk of macrosomia and shoulder dystocia without increasing the risk of cesarean delivery. Expectant management beyond 39 weeks is also associated with an increased risk of stillbirth. Relative risk equals 1.8, although the absolute risk remains low, 5.7 per 10,000 deliveries. Although the American College of Obstetric and Gynecology has not made an evidence-based recommendation on the ideal timing of delivery for patients with GDM, many physicians offer induction between 39 and 40 weeks, particularly for patients with other risks of stillbirth. For women with GDM and an estimated fetal weight greater than 4,500 grams or 9 pounds and 14 ounces, scheduled cesarean delivery compared with vaginal birth reduces the risk of permanent brachial plexus injury. It is reasonable to offer a scheduled cesarean delivery to these patients, although they should be counseled on the difficulty of accurately estimating fetal weight and the risk associated with cesarean delivery in the index pregnancy and future pregnancies. Now, what about intrapartum management of GDM? Maintaining euglycemia during labor and delivery can minimize risk of neonatal hypoglycemia and acidosis. Women with diet-controlled GDM rarely require intrapartum insulin. A variety of protocols exist to guide intrapartum management of blood glucose among women receiving insulin. But in general, glucose levels should be monitored every 1 to 2 hours during active labor, and 5% dextrose or insulin infusion as needed to maintain glucose levels between 70 and 110 milligrams per deciliter or 3.9 and 6.1 millimoles per liter. It may be reasonable to have women with GDM use only 1/2 of their usual dose of long-acting insulin the day of delivery. Clinicians should prepare to manage shoulder dystocia at the time of delivery and exercise caution when considering an operative vaginal delivery. Now, what are the recommendations for antepartum care? First, lifestyle change is an essential component of management of gestational diabetes mellitus and may suffice for treatment of many women. Medication should be added if needed to achieve glycemic targets. 2. Insulin is the preferred medication for treating hyperglycemia in gestational diabetes mellitus, as it does not cross the placenta to a measurable extent. Metformin and glyburide should not be used as first-line agents, as both cross the placenta to the fetus. All oral agents lack long-term safety data. And lastly, metformin, when used to treat polycystic ovary syndrome and induce ovulation, should be discontinued once pregnancy has been confirmed. This ends our discussion on the management of gestational diabetes mellitus. See you next time when we discuss management of pregestational diabetes in pregnancy.